Alright guys, today we are talking about eye care, okay? Now this lecture is going to split into two parts, okay? The first part is general eye care plus some miscellaneous topic, and the second part is about glaucoma. Now I know glaucoma is there's nothing about self-care there, this topic. So the reason for me to present all the different eye care pharmacological compounds or drugs is because there's nowhere in the curriculum where we can fit this type of material. So for me, I'm just going to present everything for eye here, okay, in these 2 hours that's coming up for you. All right. What's going on with your eye today?
I have dry eyes today.
Oh, I'm sorry. So what you just seen is my son, okay? It's coincident that today I am recording the lecture for dry eye and things like that, and he happened to have dry eye this morning, okay? Now, okay, so what is this picture? This picture actually was from when he was like 4 or 5 years old. He drew it. It's a depiction of a dry eye. It was actually for Halloween or something like that. So in the past, this lecture is usually presented on or around Halloween time, so it really fits the topic. But I figure this is a good drawing, good painting. I leave it in there for this year as well. Alright, pharmacology objectives. These are the listed items there. Feel free to read about it on your own. I won't read it in the video. Okay. So today, the first topic we're going to talk about are this dry eyes. Okay, usually we refer to as dry eye syndrome or DES. Okay, it is by far the most common eye diseases, and it can affect people of all age. Okay, people of all age. So there are other name for it. Okay, it can be referred to as tear insufficiency or KCS, keratoconjunctivitis. Sickers, so really they mean the same thing, just dry eye. Okay, so like I said, it can affect a lot of people. 20% of the US populations have some of the chronic problem, having chronic dry eye syndromes, and also about 40% of the visits to ophthalmologists involves something about dry eyes. Okay, so what are the symptoms? It is a combination of burning, sandy, and greedy dry feelings involving both eyes. Okay, so both eye is the key. If something just happening within one eye but the other eye is fine, you need to pay more attention. It's more than just dry eye. Okay, so that's the key. So everything happening just on one side, indicating there are something behind it. All right, so I like this movie. Do you? Okay, so let's look at some of the normal functions of tears before we talk about how to treat this problem. Okay, now so first we'll look at the tear functions. The main breakdown is here. It is for lubrications, refract light. Okay, sometimes you're looking at people's eyes are kind of shiny looking. Okay, to clean. Okay, flush out some of the foreign compounds, ducts that goes into your eyes. Nourish, it contains nutrients to nourish your eyes, and also mount immune defense, and one of those are having some lysozymes there, okay, to as a first line defense against some common bacteria there. So that is the physiological functions of tear. But I think the tear have some other functions. Tear can be very, very powerful for little kids, right? When they cry, it's like, I want this, I want this. A lot of the time, they get what they want with tears, so it's very powerful in that regard. But also, some people said it is also true for ladies, but I will leave that for you to decide if tear is a powerful weapon for ladies or not. Okay, I won't comment on that. Alright, I take a neutral ground. Alright, so here that's just the arrows, okay, showing you how the tear flows down. Okay, it comes from the lacrimal glands, goes to the far side corner of your eye, okay, and then go across your pupil and goes down to the lacrimal sac, lacrimal duct, and goes down to your nose. And that is why you get stuffy nose and and runny nose and coming all over to you when you are crying, because that is the natural flow of the tear. Alright, so besides tear, there's actually there's a constant tear film, okay, on top of your eye that is protecting or prevent liquid or humidity loss. Okay, so that's why to keep your eye a little bit more comfort. Okay, now this tear film, it's very fragile. Okay, it won't stay on there forever. Okay, so you need blinking reflex. Okay, you need to blink to replenish the loss of integrity of this tear film. Now let's look at the compositions of this tear film. Basically, it have three major layers. Okay, it's the mucin layer or the mucus layer, watery layers, and the most outer surface layer is the oily layer. Okay, now the mucin layer is coming from this mucus, okay, secreted from gold blood cells. Okay, they're mostly surfactant, basically providing some surface tensions for the water to hang on to the eye surface. And the middle layer is the water or aqueous layer that is coming from the lacrimal glands. Okay, it contains enzymes such as lysozyme and antibodies IgA that is mount the first line of defense against foreign organisms. Okay. And the third layer, like I said, is the oily lipid layer that's coming from the Mobian glands. Okay, now the idea, okay, the functions of this oily layer is to minimize evaporations. Okay, just like when you have a bowl of soup, for example, a not very well made Italian wedding soup. Okay, you have your liquid in there. Okay, and then you have a little bit oily layer there. Okay, it really prevents those steam coming out, right? So that is the idea, having an oily layer on top of the aqueous layer. Think about something, okay? Use a little bit think about brainstorm time. Okay, so now we know the tear film compositions contains mucins, water, and oil. Okay, now so think about how would you deliver a pharmacological agent through this layers or through this barrier. And the idea is, well, you need to think about something in terms of pharmaceutics and like dissolve like. Okay, like dissolve like. So all those teardrops and all these artificial tears that we are going to talk about have a fine balance between hydrophilic components and lipophilic components, so that it can go through the layers of the tear film and also replenish the insufficient composition that is in the patient. Alright, so that is the overview of these concepts of doing or treating dry eyes. So in terms of pharmacology, there's really not much. Okay, it's unlike anything else. There's no like specific target or something like that. These artificial tears, it's more like a lecture, a review of some of the pharmaceutics concepts or compounds that you learn about during P1 year. Alright, so the treatment is straightforward. You replace the tear with artificial tears that can help mild to moderate dry eye syndrome. Basically just replenish and preserve the tear film. That is the goal there. Okay, now it is designed to increase viscosity, so that it hang on to the surface of the eye for a longer period of time, stabilizes the tear film, and as well as increase the tear film breakup time, so that the overall just let it stay on top of your eye for a longer period of time. And there is a key term, okay, that we're going to talk about, and I'm going to introduce it. First is something called demulcent. Okay, demulcent is the specific terms that to describe agents that can increase viscosity used in artificial tears. So this term, I want you to know it, memorize it, understand it. Okay. All right. So let's look at the comparisons: natural tears versus artificial tears. Okay. Now, natural tears, we talked about it. You have 3 layers, okay, and different components in there. So artificial tears, the goal is to mimic, okay, is to resemble the ingredients that you find in your natural tears. So there are 5 main categories here. So water is water, okay, water is water. So the majority of the compounds in a artificial tear are just plain old waters, okay. And then we'll need some electrolytes and buffers, okay. We'll talk about it, each of those role individually in the subsequent slides. And then we'll need demulcents, okay, lipids, okay, just for looking at corresponding roles there. Demulcent, increasing viscosity, so kind of like a mucus type of a stuff, and then lipid layer, and it's made by using lipids. And we'll try to put some nutrient if possible. The only thing that is not present in your artificial tear is enzymes and antibodies. Okay, so these things you could put it in your artificial tears, but that would make the artificial tears way more expensive than it should be, and it will also decrease the shelf lives, so it doesn't serve the main purpose, which is dry eye, right? Alright, so let's look at the electrolytes and buffers, okay? You don't need to memorize these specific percentage numbers. The idea is you could do different types of products. Ideally, you want something that to be isotonic, okay? Isotonic to the tears, something about 0.9% plus or minus of 0.2. So you could vary a little bit because your eye, let's consider some of a body part that is not inside your body technically, okay? It's not within your body, so you can tolerate some variance in terms of your osmolarity and tonicity. Now you could also tune, okay, the eye drop into different tonicity for different specific purpose, okay. So chronic dry eye patients typically have very hypertonic tears because the damages happening to the epithelial layers, causing leakage in electrolytes. So in these cases, if you want to balance the tonicity, you would use hypotonic products, okay, so that you bring it back to about isotonic, okay. That is the goal. All right. So other things in terms of buffers, the ideal goal is to get it to about physiological pH 7.4, and you can also vary a little bit between 6 to 8. Okay. Now these are some of the common electrolytes in the product. Here I am just listing for FYI. You don't need to memorize these things. It's pretty straightforward in my opinion. Mostly it's just some type of a chloride salt, okay, and having HCl and NaOH is really in a very very minute little amount just to tune the pH, okay. Now comes to the second ingredient, which is the key ingredient in artificial tear, okay, so which is the demulcent, okay, high viscosity, increase resistance to flow, okay. So that is the goal, and the idea is, hey, having a higher viscosity, it will hang on to the surface of your eye for a longer time, and you achieve the goal. Increase viscosity, decrease evaporations, and also stabilizes tear film, okay. I put a star there, okay. I want you to know the functions of demulcents. What are the examples? Now I will point out some of those key examples for you to know. You don't need to memorize all these little categories, the big numbers, okay, but big categories are some of those you can get familiar with: cellulose esters, destrans, gelatins, Okay, now in terms of synthetic polymers, okay, you will commonly find a product called polyvinyl alcohol or PVA. Okay, so this is a key ingredient that is commonly used. It is non-irritating, non-ionic surfactant. Okay, so it can also have some role to promote or facilitate healing of some of the damaged corneal epithelium surface. So another common one that is being used is Povidone. Okay, so let's take a look of this. So you see that both of those ingredients are found in the bottle of artificial tear that I have at home. Those are the ones that I want you to remember. Coming down to the lipids, okay, lipids, really the idea is to provide a layer, okay, to tight seal and prevent evaporations. Things that are examples could be waxes, okay, mineral oil or paraffin. Now, waxes is tricky, okay, it's very thick, too high viscosity sometimes can tend to blur your vision. So, things that have waxes in there, it is really best for nighttime use, okay, so that is something to keep in mind. So both demulcents and emollients, okay, they can be used as a vehicle for pharmacological active ingredients. Okay, so here all we are talking about are just some type of pharmaceutics type of a concept. When you need to use your eye drop to deliver a active compound, then these agents could be helpful. The idea is to make the drug to have contact or increased contact to the surface of your eye so that you don't need to administer the drug as frequent. Okay, so that is the main purpose behind using these agents. Now looking at nutrients, so basically they are pretty basic, water soluble, mostly water soluble. Okay, that is water. Okay, water can be a nutrient. Sometimes people would add some fat or lipid soluble vitamins in there, dextrose, sodium lactate, and citrates. Those are all in very minor amounts. Okay. In terms of preservatives, okay, that is one of the more important things inside a artificial tear because when it has nutrients such as dextrose, bacteria could grow in there, and we need something to prevent the growth of bacteria. So this is a concept, a revisit from something you learned from me last year. Hopefully you remember a little bit, something about benzalkonium chloride. Okay, so it is a positively charged quaternary surfactant, and it breaks down bacterial cell membranes, and it is considered as bactericidal. Okay, remember the term bactericidal versus bacteriostatic. Okay, right? So but the downside is because it can also damage corneal epithelium. So our cell membrane or our phospholipid bilayer membrane, it's not so different than those on the bacteria. Okay, good thing is it can against Pseudomonas aeruginosa. Alright, other things can be used as preservatives such as surfactants. Okay, I won't be spending too much time talking about these little minor details there. The idea is you know some of the big categories. Okay. Right, this is FYI. Okay, this table is FYI, just giving you summarize of many different types of material that can be used in artificial tear to be as a preservatives. Alright, metals. So examples could be this thimerosal. Okay, it is a mercury derivative. Okay. Also chelating agents, okay, these could be the sodium salt EDTA. Now, I don't want you to spend too much time knowing some of these minor details of these agents because there's a lot more good content. I think you should pay more focus on there. So like again, these minor things here, it's for more of a FYI purposes, okay, FYI purposes, and I want you to just be able to recognize some of these big category. Okay, that would be enough in my opinion. There's a special category of preservatives. We call it disappearing preservative. The idea is to provide some microbial protections and while limiting some toxicity. Things such as sodium perborate, okay, it will break down, okay, into H2O2 and then oxygen and water. So it would be gone, okay, very quickly once it's put into the eye. And the amount of peroxide generated in the process is very small and it's not going to produce eye irritations. Other things such as purate is some compound that can be break down by UV light. So as soon as it leaves the bottle, okay, put it onto your eye, the light goes through and then it will be disappearing. Alright, so let's look at a label of a box that is for artificial tears, and you can see some of the ingredient glycerins and glycol. Those are used as a lubricant, okay, and that is and you can also see the other things that we talk about listed as inactive ingredients, such as these benzalkonium chloride and other salts to adjust pH as well. And here is another versions of artificial tears. So here you have your key ingredient as the PVA that we just talked about as the main ingredient, and inactive ingredient, again, a lot of these sodium chloride salt and a minor amount of sodium hydroxide may be added to adjust the pH. Okay, so dry eye is pretty straightforward in terms of artificial tears. Knowing the big categories are the key, unless I highlighted such some of the minor lines there. Alright, so next topic on the eye we're going to look at is red-eyed. Okay, now think about your body. What it's the only thing, okay, inside of your body that is naturally red. Okay, naturally red, it's blood. Okay, when you see something that is, red, okay, usually it's associating with some, your blood and also your blood vessels. Okay, so the reason for seeing red eye is caused by increased blood flow, okay, or eye vasodilations toward the areas of the white part. Okay, so it is often associated with fatigue, dry eyes, allergies, and other inflammatory reactions. Alright, so idea to treat red eye is first to relieve the symptoms, okay, and if there is a underlying cause that is treatable, we'll also treat it as well. So to relieve the symptoms, I will reverse the vasodilations that is happening. Okay, so that the goal is to induce vasoconstriction. Okay, vasoconstriction. Okay, vasoconstriction locally. Okay, locally is the key. We don't want it to happen everywhere inside the body, just the eye. Okay, and at this point, you probably have some red eye or dry eye from watching so many videos online, right? So, if you need to take a break from this point on, pause it and go take a little quick break. So I hope you take some break, okay, if you need to. If you don't need to, well, let's keep going on this lecture. Key things about treating red-eyed, okay, treating red-eyed is use agents. We collectively call it sympathomimetic, okay. So these are the agents that mimic the actions of endogenous neurotransmitters and hormones of the sympathetic nervous system. So something that mimic the actions of norepinephrine and epinephrine. So I put a big star here. I want you to put a couple more stars here, because this type of agents will come back. Talk about in these agents in greater details during the topic about cold. Okay, so hold that thought here. Now, so for treating eye, the mechanisms is rather straightforward. Okay, to relieve the redness, the idea is to induce vasoconstrictions, okay, by stimulating your alpha 1. Okay, alpha 1 receptors, okay, alpha 1 adrenergic receptor mediated constrictions. Okay, so that is the key there. So that is the key pharmacological idea. Induce alpha 1 mediated vasoconstriction. Alpha 1 vasoconstrictions. Right? Why do I say it many times here? Because students tend to forget in the many years that I've taught this topic, and I want to say it with you. Alpha 1 adrenergic receptor mediated vasoconstriction. Say it with me. Yeah, it's embarrassing, but you're alone at home. No one's watching, right? So alpha 1 adrenergic receptor mediated vasoconstrictions. Remember, alpha 1 stimulations, vasoconstrictions. Okay? Why? Because it will come back. It will come back. It will always come back, this concept. Trust me. So you have vasoconstrictions, you're narrowing the vessels, decrease blood flow to the area, decrease redness. You achieve your goal there. Okay. Now the downside, okay, it may also cause dilated pupil. Okay. And also, once these drugs are gone, okay, in the area, you may have rebound hyperemia, okay, i.e. rebound redness coming back out. So what are the examples of agents can be used in this area? Okay, for non-specific adrenergic receptor agonists, we have phenylephrine. Okay, phenylephrines. Okay, more specific alpha 1 stimulations, we have compounds that are ended with Zolan. Okay, Dr. Pezzino will talk more about these different top products in her lectures. For me, if you remember these Zolan compounds that are specific for alpha 1, that is good. Okay, that is good for me. So let's look at the pupils, okay, what's going on with these medications. Now the pupil have two layers of muscle, okay. So the first layer, the inner layer, is the sphincter muscle, pupillary sphincter muscle, okay. It will contract lead to actions called meiosis, okay, with the stimulations of your parasympathetic nervous system, i.e. using acetylcholine binding to M3 receptors. It will cause these sphincter muscles to constrict, okay, so you get a constriction of your pupil, okay. On the other side, the other muscle group is this radiodilator muscle, okay, radiodilator muscle, which is on the outer layer of your pupil. So the name tells you, by stimulating these muscle, it would have a local contractions on the outside of the ring. So it basically, you pull open the ring and you get your dilated pupil, and this action is controlled by your sympathetic nervous system, i.e. having epinephrine and norepinephrine binding to alpha 1 receptor, okay, will cause these pupillary dilations, okay. Now this mechanism is exactly the same mechanism as the way we constrict our blood vessels to reduce redness. So you see why these medicines would have these side effects, okay. It will relieve your redness, at the same time you have dilated pupil. Now the problem with dilated pupil is that you can't focus very well. Your visions may get a little bit blurry temporarily. So let's look at these structures, okay, midazolam compounds in a little bit more detailed way. Now these compounds have a pKa of 9 to 10, i.e. they have very little ability to cross the CNS, so they will be localized in that area. So I don't want you to pay too much attention in these little structure there, but the idea behind having a functional group or out group is to provide some selectivity over alpha 1 adrenergic receptors. Remember, those receptors are all next to each other there. What decided this compound to bind to this one more versus the other one, a lot of the time is depending on the specific structures and functional groups, okay. So sometimes the redness is because of coming from allergies, okay, from allergies. If that is the case, treating allergy, okay, would be a way to also to help with the red eye, okay, help with the red eye, okay. Now during these local allergic reaction, histamine is gonna be released in the process, and overall, okay, it will bind to these G protein coupled receptors and ultimately lead to all these symptoms: vasodilations, redness, itchiness, swelling, pain, lacrimations, just discomfort. Okay, if histamine binding to histamine receptor is the cause of it, okay, then how about we will use antihistamine, okay, antihistamine, things like ketotifen, okay, to block the actions, okay, to block the binding to these H1 receptors, okay, H1 receptors. So a lot of the time, these ketotifen is found in combination product along with nafazolins, okay, at the same time, so to treat the symptoms and as well as treating the underlying causes for these red eye. Now the problem with antihistamine is that it have anticholinergic effect, okay, anticholinergic effect that will lead to, okay, the opposite of constrictions, i.e. dilations. If cholinergic cause your pupil to constrict, then anticholinergic is causing it to dilate. Okay, so you get two actions to causing dilate. Okay, both alpha 1 stimulations cause dilations, and antihistamine binding have an anticholinergic effect, so it will further dilate your pupil. Alright, let's look at another box examples here. Look at the active ingredients. Okay, we have PVA, okay, povidone. Now these things are the same, okay, these really are the same things. And then we have something, the zolin compound right here. So that is treating your redness, okay. So technically, I don't think this should be called triple actions. It's triple ingredients, but I think it's double actions. So I'm criticizing the naming of it. You shouldn't be. I'm just kind of messing with it. Alright, so that is the idea behind treating dry eye, treating red eye. So those are all common problems that a lot of people face, and a lot of people seek over-the-counter medicine for help. Now coming up, we're moving on to topics that are not over-the-counters, but they are related to eye, and it is just a place for me to bring in everything related to eye in right now, okay? So here is a condition called age-related macular degenerations. Age-related macular degenerations. So let's take a look of what this disease mean. Okay, here the top panel we have a view of a normal visions. Okay, looking at a house. And your focal point when you're looking at something is at this macular regions on the back of your basically near the back of your retina there. Now if your focal point, okay, macular have some type of a degeneration process, you know, due to multiple reasons, okay, you would have loss of center visions, okay, the middle of it will start become more blurry or even disappearing. So age-related, the name tells you it is because of aging, okay, you would have some type of abnormal blood vessel growing in the regions and therefore distorted the visions. Right, so here is a comparison of normal visions again with a more advanced stage of AMD. So it started with the center, but ultimately the side of it will also get a little bit blurry compared to normal visions. So the cause is having neovascularizations in the area, growth of new blood vessels, but unfortunately these blood vessels growth are abnormal. They are usually leaky, okay, and also damage the area where you receive light, okay, and creating blind spots in the center visions. So what caused the growth of these new blood vessels? It is a compound inside our body, okay, called vascular endothelial growth factor, commonly abbreviated as VEGF. Okay, VEGF. Okay, this compound stimulates blood vessel growth. Okay, blood vessel growth. Now, The idea to treat this abnormally is to use something that can reverse the process. All right, something anti-VEGF agents are typically used locally with injections, okay, to the site, and therefore help to stop those abnormal growth. All right, so this one is a FYI only. It is very complicated process of having this blood vessel growth VEGF bind to VEGF receptors, okay, and lead to a series of signal transduction events and ultimately lead to the blood vessel growth. And the drugs that we use, okay, the overall idea is like, let's stop this process at different point, okay. We could have an antibody, okay, that bind to the VEGF so that it doesn't bind to the receptors, okay. We can also have drugs that stop the pathway of the VEGF, also stopping some of the dimerization reactions happening upon binding of VEGF to the receptor. So all these various places can be interrupted to stop the growth of the blood vessels. Okay, now this picture itself is FYI. Okay, we'll go into talk about some of these agents specifically in the couple slides afterward. So the first one here is the bevacizumab. Okay, this is an antibody drug. Okay, antibody drug. Okay, now you will learn a lot more about antibody drug next semester in another module, and as well as in immunology and biotechnology. So this antibody bind to VEGF so that VEGF could not bind to its receptors. All right, something we have also a different antibody drug. Okay, ranibizumab. Okay, ranibizumab. Okay, all these map, okay, really refers to monoclonal antibody drugs. Now, the third one here, we have something called the pegadricib, okay? The brand name is called macular. Now, these drugs, although you will never see it in the pharmacy, but still there is, this common agent that is for the condition. So you will still be responsible to knowing those, okay, further down in your career. Now, this pegadricib is a special drug, okay, special drug because it is not an antibody drug. It is actually an RNA oligonucleotide aptamer drug, okay. So aptamer, this is what I research on, this is what I got my PhD on, so I got excited whenever I say aptamer. Okay, so one of you guys did some in the class did some research with me and know a little bit more about aptamer, but the concepts are not rocket science. The idea is having some type of an artificial sequence of these nucleotide, and it will form a structure, and these structures can serve almost like an antibody and bind to the same target VEGF, so that the VEGF doesn't bind to the receptor and lead to stopping the growth of the blood vessels. Alright, so another one here to wrap up this lecture. Here we have something called aflibercept. Okay, I may have butchered the name, but I try my best. Now this is, like I said, also in injections, okay, directly inject to the eye. Now, this type of a sap-ending biological agents, usually they are some type of a soluble decoy receptors. I underlined it, I circled it, because you will see some type of a similar things later on in your different classes. Sap, okay, usually refer to a decoy receptor. The idea for the decoy receptor is to trick the VEGF and other growth factors to bind to, so that it will not bind to the normal receptor that is expressing on the cell, right? Giving them a fake thing, okay, to lure them away, and therefore ultimately stopping the growth of your blood vessel. So the idea is quite straightforward. These little lines here, I want you to just be FYI. Just remember, overall, okay, there are a couple actions, okay, that is to stop the vascular growth, and we've talked about the three, basically the two main way is, first you can bind, okay, VEGF. Okay, you can bind to this guy, okay, so that it will not bind to the receptor. okay, or you can give them a fake receptor so that it doesn't bind to the receptor, okay, on the cell. So I hope that summarizes the overall concepts behind how these antibody drugs and fake receptors and aptamers work. Okay, just pay attention to which one is the fake receptor, which one is the antibody. Okay, so the next slide is a little bit gruesome. Viewers, discretion is needed. Oops, that is painful. That is painful. Yes, this is how these drugs are administered. It's a local injection, so that's why I said you will never see it in your career probably, but nevertheless, these are compounds that will still be asked and pop up on your NAPLAX exam, so you are responsible for knowing these. Okay, so that is all for this part 1 of eye lecture. The next one, we will talk about glaucoma. Okay, glaucoma is nothing about self-care, but this is again the one area we introduce different types of eye diseases. Alright, so that is the end of this lecture, and I'll see you in the next one. Bye.